Good morning. This is Michelle Hager, and thank you for joining our Blue Cirrus Consulting webinar today. I'm pleased and honored to have both Christy and Amanda. We'll introduce in a moment to talk to you about some of the things that you need to do to make sure you're meeting an audit and managing your organizations. This webinar will be recorded today. Any questions that you might have, please ask those in the Q&A chat, and we will monitor that throughout the presentation. We will stop with each section that Amanda and Christy have defined and ask any questions related to that question and related to that section, and also share information at the end of the presentation for their contact information as well for any questions that are lingering beyond the presentation. Again, this is being recorded, so this will be available on our website probably in a day or two. Usually we get them up in a day or two. There are previous webinars on our website as well. So if you're interested in looking at some of the other topics that we've covered, those are located in our Knowledge Tsunami on the Blue Cirrus website. With no further ado, I will like to introduce both Christy and Amanda doing this presentation today to protect yourself from a telehealth audit. We know that Joint Commission, as well as other governing bodies, as well as the federal government, OIG, et cetera, they are now more and more interested in telehealth. So we thought this was a timely topic, and we have a great couple of speakers. Myself, I'm the host of this webinar, so occasionally I may ask questions directly to Christy and Amanda as it comes up, and I think you all have seen my bio previously. Christy, who is known among her colleagues for passion, leadership, and healthcare, can certainly attest to that. She's got tons and tons of experience in telehealth and compliance. She's recently been recognized by a large healthcare organization, receiving the Innovation and Quality Award. This is given to an individual who's improved the quality of care by developing or instituting a new technological paradigm. Christy is a native Midwesterner. Her experience is as a certified coder and compliance officer through AAPC. She has a bachelor in health management from Southern Illinois University, recently completed her master's degree from Colorado State University. A native Midwesterner, as I said, but now calls Lehigh Valley, Pennsylvania home, where she lives with her family and 3 rescue dogs. So welcome, Christy.
Thank you.
And Amanda Bonacor is the manager in Coding and Reimbursement Department for Northwell Health. Northwell Health System in New York is comprised of 23 health systems and over 3,800 employed physicians. She's CPC certified. Prior to her role at Northwell, Amanda received a Master's of Fine Art from Cranbrook Academy of Art. I hope I got that right. She credits her out-of-the-box thinking and ability to interpret abstract concepts and desire to approach tasks collaboratively to her studies in the arts. I understand that completely. In addition to the teamwork that she does, she works collaboratively with physicians, service lines, legal, procurement, and compliance on business plan development, new initiatives or services. And Amanda is a member of both the Telehealth Exploratory Committee, Electronic Medical Records Committee, Connected Device Committee, and in 2020, Amanda was presented to the national audience on the remote physiological monitoring as a panelist for the Center for Telehealth Policy and E-Law, commonly known as CTEL. Amanda is also a volunteer in animal rescues, and cats are her favorite animal. So lots and lots of animal lovers here. I'm also an animal lover, so we're happy to have you. Christy, I'm going to now turn this over to you as the host. At some point, you can either you can either advance the slides for Amanda, or you can turn it back to me as the host if you would like to have me advance the slides for Amanda.
Okay.
Okay, so you should be the host now.
Okay, and just
I want to make sure you can advance the slides.
that's what I'm looking for is it did give me control. I saw that, but I'm not seeing. And it's not moving on a click.
Okay, well, there are a few ways to skin the cat, no problem. So I will reclaim my host. Oh, there you go. Now you should be able to move the slide deck. There you go.
There we go. Oh, too far. Let me go back. Can I go back?
Yes, you can. Do your arrow back. There you go, previous.
One more. All right, we'll get started.
Perfect.
All right, thank you everybody for joining. This is a topic I think is very timely, and I think many are, interested in. We here today, these objectives we want to go through, and really in a nutshell, we want to make sure that you are confident in how you're documenting your telehealth services, or just walking away feeling reassured or confirmed that you're on the right track. So that's our goal today. Okay, so what I'm going to start with is just a very brief telehealth timeline overview. I'm sure most, if not all of you, have lived through this, so you know this, but it's kind of good to just kind of summarize it and reflect a little bit. So before March of 2020, there was really very limited telehealth care delivery across the nation. The latest statistic I saw was about 2%. Now, in some pockets it was higher, in some organizations it was higher, but overall it was about 2%. Well, then March came, and we all know what happened. We had to figure out how to see patients, and it became the anything goes under waivers. Telehealth is being done. It's like, it is the hot thing on the market. And that kind of went through January to 2021, and some statistics show that up to about 80% of care was given at peak times during COVID in some sort of telehealth capacity. Well, then we get to about January, and things are starting to move back into a direction of semi-normalcy. And so we, as the, in organizations and the payers, are trying to figure out how to navigate this new normal. I think there's an understanding that we're not going to be able to live in the anything goes world in the wild, wild west, but that we are not going back to where we were pre-COVID. So we have to figure out what that is, what that looks like, and navigate that. And so what part of those pieces are the regulations and guardrails are starting to be put in place. And that's what we need to start paying attention to as we move into this new normal. And I'm going the wrong way. Okay, so just a brief overview of kind of what is starting to come out. The OIG announces where they're going to start with their telehealth governance and their audits, and some of it is just reviewing to make sure that certain criteria is met, and other is to check things such as the security of the technology using. So in phase 1, they're going to be reviewing E&Ms, opioid use disorder services, and stage renal disease psychotherapy. Going into phase 2, they're going to look at Part B services. They're going to be looking at those distant and originating site locations, and we're not sure yet where that's all going to shake out. Virtual check-ins, which we'll talk about a little bit later, as well as e-visits, remote patient monitoring, use of telehealth technology, and then they're throwing in annual wellness visits to that review. So this is just a small overview. I'm sure many payers are doing their other, they're starting to review this as well. So I'm going to start out very general. We're going to move on. We're going to start general and get a little bit more specific into documentation. So first thing I want to point out is general telehealth documentation. What stays the same? When we're talking about parity or the one-to-one and in-person to telehealth, so you're basically doing for telehealth what you would have done in person. The documentation guidelines do not change. The basic documentation guidelines for the code itself must still be met. Just because if it requires some sort of exam component, then you have to figure out how to document that exam component, and more to come later on that. We're not off the hook for that. So everything that is required for the code must be met to bill it telehealth. So there's certain services that obviously would not be conducive to telehealth. And the general principles of documentation, still apply. They're here. None of that goes away. So that all remains the same. And In addition, go to the next slide. What's different is that you have some additional pieces to consider as you are documenting. And as I go through this, not all this necessarily needs to be in the notes. It can be, if you want an easy place to find it. It just needs to be accessible, and you need to be able to demonstrate these different things if you were to be audited. So first is consent, and different states, different rules on how they want consents. So if you have a written consent that you have on file, that's fine. I think a lot of providers at this time are doing a verbal acknowledgement and documenting that in their note. But whatever your organization has come up with, there is the consent issue that needs to be considered. Location of the patient, 3 things here: location of the patient because of state licensure, for any escalated protocols you might need should there be an emergency and you need to just dispatch someone to the patient or get them to the nearest facility. And also for originating site reasons, as we go back into potential restrictions on originating sites. And then the provider needs to share with the patient their location, credentials, and credentials, and then also the name and credentials of those in the room, or that there is nobody in the room. Really important to let the patient know. This can also be in a general consent. Many are adding this. They have the right to terminate the telehealth service and request alternative care at any time. So we see this as just giving care, right? So, but right now, telehealth is still looked at as almost a procedure where informed consent, or that they have the right to not receive care in this way, is there. So just letting them know that they're aware of their rights and maybe having that documented. And then what platform what platform is being used, and noting that it is a secure platform. So even though we were left, off the hook for a few months as far as what platforms we use, that will definitely not stay in place. And all of this, again, does not necessarily have to be in the note. Some people include a template within their note to capture this information and prompt providers to get it in there. Or you just need to know where it is should you be monitored, audited. So those are the additional pieces that you want to consider over and above our documentation requirements that we have to do every day for any service that would be in person. So with that,
I'm sorry, can I just add to that? So with the consent, one of the things I see with some of the systems from a telehealth perspective, just to caution folks, is that there needs to be like an active consent. They need to say they saw that consent and they actually accept it. Sometimes with some of these systems, they're a little bit like you're accepting a whole bunch of stuff and then there's also a consent thrown in. So just be careful about that one. I think that's one to be concerned about. And then on the platform security, what we're finding is a few of the platforms that are out there that may have been quickly proliferated at the beginning of COVID are not necessarily as encrypted as others. So really drill on some of your vendors when you're either selecting them or now that you've been using them for some time, finding out from an IT perspective whether or not that data is really encrypted. Is it onshore, and how often do they do updates, et cetera, that sort of thing.
Those are some great points. Thank you. And yes, the consent piece, even if in writing, and if it's with other pieces of information, it's good to always acknowledge that there is a consent and that the patient understands that they signed that. So now we're going to move on to some more specific things, and I'm going to the telehealth exam, and there's some myths and we need to demystify the telehealth exam. And so I'm going to pass it over to Amanda as she starts to dig a little bit deeper into the documentation.
Hi, everybody. Can everyone hear me?
It's kind of light, Amanda. You're not far away, it seems like.
Okay, how about now?
A little bit better, yeah.
Okay.
And I need to get back the
control.
Do you mind advancing the slides for me, Christy?
Sure, I can do that. Yep.
Okay, perfect. All right, so you could go into my first slide.
Okay.
Next one, yeah.
If I can. It's being finished. There we go.
So the way I consider the telehealth exam in the overall documentation of a telehealth visit is where people are going to look for plot holes, right? So after you designate how you perform the service, that consent was provided, the location of the patient, the location of the provider, and names of any persons involved, then you get into the content of your note, which, as Christy mentioned, is no different than we would document a prior visits or in-person visits. Some things to consider, we consider these the critical practices around the telehealth exam: prepare, explain, and escalate. So under preparation, I know, as mentioned earlier in the webinar, many people, their first experience with utilizing telehealth in their practice was during the public health emergency. And I know, being based in New York, it was a very rapid setup and extensive education in a short period of time. So some elements were reviewed to see how can we physically perform these examinations on patients when we used to look at the platform as a low acuity or follow-up for follow-up purposes, where you had a little bit more control of who you would recommend the service to. Now it was open to some of our more higher critical patients that we wanted to stay at home for their safety. So things to consider are a creation of standardized practices and procedures for physician-directed and performed self-exams. So one thing to keep in mind with the self-exam when we look at documentation is, when we think of the old format of a SOAP note, you have a subjective, objective, assessment, and plan. So you want to make sure that your examination cannot be considered subjective, right? So you're going to be giving directions to a patient, but you still have to have an objective documentation around that. The other thing to consider is a list of patient at home toolkit that can be shared prior to a visit. So depending on how you are performing your telehealth visits, if it's in your standard practice with follow-up patients, you may be able to share with them, based on the reason why they're making the visit, a list of items to include when they join the telehealth visit. This is particularly used around like neurology and orthopedics, who have to maybe do range of motion reviews of the body systems. So they may ask a patient to bring a chair or a broom, something that will assist them in getting that objective information around the exam. Additional items in a toolkit that are typically used by primary care may be a weight scale, a thermometer, pulse ox if you have one, a blood pressure cuff, or there's even ways to write up directions on how to have your patient count their heartbeats and give that information back to you. We've also seen with ENT, the ask for an outside light source, potentially either a flashlight or additional light source out of the camera light source that's used for the telehealth visit. With that in mind, your documentation should always match the modality utilized. So things to keep in mind with the templates is you want to make sure the language that you're putting in the exam is consistent with how you obtained the exam elements. This, again, is where you're going to see the plot holes come in. And we always ask the doctors to add necessary narrative to identify how hands-on exam elements were obtained. Now, this could be specifically in your note, or if questioned, you could refer them back to your standardized protocol on how you would have obtained that element. Escalation is also very important. So depending on the type of case, If it is a established patient that you know would benefit from updated lab work, there's always the ability to send them prior to the visit to have that content readily available at the time of the visit. If something occurs that you need to escalate the visit immediately, have a plan in place for terminating the visit, and if possible, either sending EMS to the patient or deploying devices to the patient to get those necessary diagnostics. You could go to the next slide. So one thing to keep in mind for identifying potholes is things that were set up prior to and some recent changes. So all electronic medical records have, the ability to do guided exam templates. Depending on what system you're utilizing, sometimes they're user-friendly for the physician, and then the content is printed differently, right? So you may say a system is completely negative, but perhaps the language that transpires onto the note adds a little more context to that negative body system or positive body system finding. So we always ask that you review any of your guided templates just to ensure they're not incidentally creating those plot holes in the exam. Another thing to keep in mind is copy forward. So anything that you copy forward or any macros that you use commonly, just make a note of it to review them and make sure that the content again matches the modality that you're using. And if you could always decide to make a version of the same macro that is consistent more with telehealth. So if you changed it to, this is my telehealth version of my ROS or my telehealth version of my supervision, then you could keep those separate. And then one big myth, right, is the 2021 evaluation and management guideline changes, where they say, they lessen the significance around the documentation of the history and exam, but they don't eradicate it, right? So it's still very important. So just due to the lack of it being a bean counting scenario in which you have to hit certain criteria to meet your level, doesn't mean the documentation isn't pertinent to your evaluation of the patient, your consideration around their assessment and plan, as well as the documentation for continuity and care. So how to avoid these? Again, documentation should always match the modality utilized. When the hands-on exam elements are obtained, add that supporting narrative on how they were obtained, or have documents that you could share to show your practice-specific protocols. Review all your copied notes and macros, and if you want to, make a telehealth version of them or edit them in your note to make sure they match your modality. And all pertinent and relevant history and exam elements obtained during the patient visit should be documented in the record to ensure continuity of care. So again, just because the 2021 guidelines no longer focus on hitting a certain number of each of those elements in history and exam doesn't mean it wouldn't be used to support the medical necessity of the visit. Does anyone have any questions?
So for the changes in the E&M codes that you just referenced, were there any big ones that, or maybe you're about to talk about those, but were there any big ones that sort of came up for you that you thought this is something we need to make sure we're aware of?
Level wise, you mean?
Yes.
Well, I think that if you have a patient who's telling you they have an exacerbation and you're going to do a medication renewal, it may meet a certain level, but you still want to make sure that assessment and plan is documented, right? So in the past, when we would have to think about our level 4s or level 5s and doing comprehensive examinations or detailed examinations, it was a little impractical to complete that via telehealth. but it doesn't mean that it wasn't a requirement for the service to generate that assessment and plan. So I think those are your areas when you're just hitting in the MDM. You still want to make sure the content of your note supports the medical necessity for that level, and anything that you were able to obtain, just documented. I think that's where a lot of people target, or a lot of auditors are targeting. How is it possible to perform these levels of service via telehealth?
Yes.
But when we look at, I have examples from my hospitalists and some of my physicians, and in New York, we got hit hard in the beginning with the pandemic, and really it was up to them to figure out how to meet those requirements for their chronic patients or their patients that they feared to come into the office. And they did a great job in coming up with the examination protocols and meeting the requirements, not necessarily to meet a level, but to actually treat their patient and keep them safe during that time. So at this point in time, I don't believe it is a valid argument to say that it can't be done, because it had to be done. It's just important to make sure you keep that content within your note so that, again, the plot holes aren't picked at and allowing them to continue to question that those levels are irrelevant for this modality. I don't know if that answers your question, Michelle.
Yeah, no, appreciate that. That was very thorough. I also want to make sure, I know Amanda is managing the chat and the questions. Anything in there? Oh, Amanda Powers, excuse me, not Amanda. We have two Amandas on the panel list. Nothing's there, she's telling me. So great. Thank you so much.
Yeah, that was great. And I can attest to some of the work that I saw that Amanda shared with me that their hospitalists had done. And I think that's a great idea, is to put things together for your specialty. Again, not just to meet the work, but to really start to know how to really conduct a successful telehealth exam. Okay, I'm going to move this forward. I had the controls, I had little buttons, but they went away. So I'm not sure what's happening, but.
Yeah, if you can either use your arrows on your keyboard, or if you sort of, move your mouse around in the bottom left-hand corner, they should appear.
They were there and they went away.
Michelle, it looks like you're the host again.
Oh.
Oh, okay. That's why.
That will affect it. Sorry about that. All right, let me put you back.
Okay. There we go. Come on. There we go. Okay.
Perfect.
So this part of the presentation is going to get into some non-parity visits. And what I mean by that is visits that really are not a one-for-one. They're more true technology-based services, right? And that's what Medicare CMS calls them. And they have a little bit of a different flavor, although we think of them as telemedicine. They have some different guidelines. So there's a lot of information in here. We could probably spend an hour on each of these, if not more. So I'm going to try to unpack this at a high level, so you can have a few takeaways to go back with you. So virtual check-ins and audio E&M codes. So I'm going to go virtual check-ins. These services were actually they're like a phone triage almost. In talking with a lot of providers, it's really those phone calls that we've always done care via phone, but it's never been reimbursed. Well, CMS started to reimburse that a couple of years ago, and that was pre-pandemic, and we expect that will continue post-pandemic. So that's really to capture those quick, brief calls where you do give some advice. There are some rules around it. We'll talk about it in a minute. So come the pandemic, and those telephone evaluation and management codes that no one ever used because they were never paid are now all of a sudden being paid by everybody. So now you have these virtual check-in codes, you have the E&M, telephone E&M codes, and when you read the guidelines for both of them, it's almost word for word the same, couple of nuanced differences. But it required checking with the payers. Now everything that we have been seeing in any communication with payers that I've had, they are considering audio only permanently, using these telephone evaluation and management codes. So that will be something that may be considered. So virtual check-ins, absolutely will continue. Don't see a reason why they would stop that because it was pre-pandemic. The telephone E&M codes may now be added. Now, telephone codes billed as parity to E&M codes. Some payers allowed this during the pandemic, where if you were not able to connect for a technical reason, I think that was pretty much the intent, that they would allow you to go ahead and still bill it as an actual E&M service. I'm going to go out on a limb here and say that's not going to continue post-pandemic. So I think most payers will look to, okay, we're now going to pay for audio only, but it's not going to be at the same rate. So that leaves us with the virtual check-in and or the telephone evaluation and management codes. So just some quick guidelines and considerations in your documentation around virtual check-ins and audio E&M codes is, number one, all of this, you're going to need to come up with a workflow to capture this, because right, this used to be not captured, it wasn't captured, it wasn't a formal workflow, but to really get this and get it right, a workflow needs to be in place. But that consent, again, still needs to be there. Our providers that I've worked with got used to doing that during the pandemic. Where they would, say, hey, I'm treating you virtually. Are you okay with that? They even were okay saying, it's a billable service, and not one person has said they said no. So I think not only providers, but patients are getting used to that question being asked and acknowledging that. The provider-patient relationship, again, outside of the PHE, it's going to most likely go back to being an established patient. So if it's not in the note, you need to have it easily accessible or be able to easily demonstrate that relationship. These are time-based codes, so you want to document the total time spent in discussion with the patient. The timing of services. So for the virtual check-ins, the timing cannot be related to an E&M service by the same provider in the past 7 days. So if you saw the patient for pneumonia 5 days ago and they call in and have a question about the prescription, and you end up changing it, it's going to be considered part of that service that you did in that period. But if it's outside of that, it's 2 weeks later, and now they have some blood pressure, and the blood pressure, the blood pressures are kind of ranging, higher than they want, and maybe change a medication or something, that would be acceptable. The other thing is that the phone call cannot end in the decision to see the patient in the next 24 hours or next available urgent appointment. So just consider those timeframes. The audio E&M codes actually do not have this. Their only timing talks about being billed cannot be billed on the same day as an E&M. So that's going to be probably very payer specific as to what guidelines they're going to follow, depending on the codes that they choose. So make sure you follow your payers closely on that. You want to document reason for service and clinical advice rendered and the medical necessity diagnosis. Now, previous phone calls, you may have jotted something down in a telephone note in your EHR or something like that. But now that they're actually billable services, in some instances, you want to make sure that you do have a clear reason for the service, that medical, to define that medical necessity, and also the diagnosis that will need to go on the claim. Just a side note, virtual check-ins with CMS also include for other forms of communication, such as text or email. If communication is not telephone, ensure method of communication is documented. Okay. E-visits. These are non-face-to-face patient-initiated visits with the just physician, not only physician, but provider, through a secure online patient portal, usually the EHR portal. These codes specifically are the 99421 to 423 are for providers who are able to bill E&M codes. They are able to bill Medicare and eligible to bill the evaluation and management codes. These other codes, the G codes, are for providers who do have a Medicare, are able to bill Medicare, but they are not eligible providers to bill E&M codes, such as a physical therapist. So for these for the document on e-visits, the message exchange that you have in the portal would actually serve as the documentation of the service. That's the easiest thing to do. Why summarize something that's already there for you? And most EHRs have a way to make this happen. If not indicated in that exchange, there needs to be some sort of a demonstration that patient initiated. I think if the patient starts the conversation and you're happy the exchange as your documentation, that's going to be very evident. If not indicated in the exchange, again, back to that provider-patient relationship needs to be documented or very well able to demonstrate that was established. These are time-based codes again, so but it's not just on one day, it's a cumulative time. It's a discussion over 7 days. So you could go back and forth with the patient over the course of 7 days, and you would add up the total time spent in the course of 7 days going back. Most providers that I've talked to that are starting these kinds of visits, it's a one-day exchange, but just keep in mind that it can, you can go back and forth. It should not be reported on the same day that you do an E&M service. Again, if not indicated in the exchange, make sure you summarize that clinical assessment and plan. And I would really encourage anyone to leverage your EHR for templates or modules for the service. Don't reinvent workflows here. Again, we're starting to put some structure around something that we've never really done before. And there's modules and help out there to put that in place. So I really leverage what you have already. Remote patient monitoring. This one I actually thought, geez, we want to go into this because there's so much to talk about. But I'm going to go through, we're going to look at some general documentation considerations with remote patient monitoring. I want to just disclaim that these codes are brand new. And remote patient monitoring has really not been a reimbursable service for very long. So the codes are morphing and changing, and the guidelines are pretty gray, even with these new codes in place that were supposed to make it a lot easier to start billing. But things you want to consider just generally in remote patient monitoring is you want to make sure that the medical necessity for monitoring, the parameter that you're monitoring, and summary of the plan is documented. So basically in that visit where you're establishing either care or you're establishing the plan, is you want to document that summary of what you're going to be doing, and must be a minimum of 16 days outside of the pandemic. Patient consent to be monitored and that provider-patient relationship. So obviously, if you have a plan in place at a visit, that demonstrates the provider-patient relationship, but that consent, patient needs to agree to the monitoring that you've proposed as the plan. Document the device, brand, model used. It must meet FDA definition of a medical device. That has been confused with medical clearance, which is not necessarily true. There can be some that are cleared, right? But it just needs to meet the definition of that FDA medical device. And then monitoring of multiple parameters on separate devices should only be reported once per provider per 30 days. So even if you're hooking your patient up with multiple things, you're strapping them up, really, these codes are considered all-inclusive, whatever you're working on. They're looking at this as more of a holistic kind of service.
So Christy, I have a question and then I have a comment. So the devices, I would say for folks, we get a lot of questions around whether or not it can be self-reported information. And my understanding, and I think it's your understanding, but please correct me, this needs to be Bluetooth data. It can't be self-reported blood pressure, self-reported weight, et cetera. It has to be Bluetooth device.
That is correct. There's one code that in the next slide that we'll go over, they may be able to get to around that, but for these newer codes, it must be digitally transmitted.
And then my question is, what about for the remote patient monitoring or remote physiological monitoring, whatever we want to call it, the code charging of that? When I'm getting a lot of questions around, okay, if I'm a physician and I'm doing remote patient monitoring for CHF, but then I'm also, the patient has an endocrinologist and they want to do remote monitoring for diabetes, are we now colliding and only one of those physicians can do an RPM code charge? And if that's the case, who gets the charge? The one that gets it first, or how does that work?
So I'm going to say that that is one of those areas that is still up for, we're not sure how that's going to happen. The way it reads, there's debate. So it will be interesting to see how the payers interpret how it reads. I've read it as basically one provider is going to be paid for all monitoring happening on a patient, which in those scenarios is one person's going to be out. My understanding is that the intent of these codes is to be more of a centralized kind of monitoring thing within an organization, right? So, or that it's done by the PCP and the PCP is then collaborating with the specialist, or that there's a centralized monitoring solution where then that monitoring center deploys or gets information and alerts back to the appropriate provider for that device or that parameter. And I would ask Amanda to jump in if she's got some additional insight.
Yeah, I already told Chrissy she was brave doing a one slider on RPM. So yeah, so the way it reads right now, it's one physician. We do, when we look at overlapping, we always go back to if there's a more specified code based on what element you want to monitor, keep it separate, stay in your lane. So don't convert a CGM to an RPM, because the endocrinologist may be able to continue to do the CGM while a primary care physician or cardiologist explores RPM. And at Northwell, we always start with the use case, right? So we always understand the condition, and depending on what you're monitoring, there's so many different pathways to take. So we try and explore each of the pertinent pathways. For instance, CHF can be monitored if you're doing blood pressure monitoring. Blood pressure monitoring has multiple different pathways. You could do the self-measured one, which reduces the reason, you know, the automation of it. You could do, I think there's the ambulatory set of codes, as well as, you know, the RPM code. So we explore every use before we determine that the RPM is most valuable for that team. But we do keep in mind that there may be overlapping. One area to explore that is gray is that 99091 code by the subspecialty that might be looking at one pertinent element. Yeah, so, you know, CMS came out saying that it can be billed during the same period of time as the RPM codes. So if the main provider isn't using that code, but collecting pertinent data that might be relevant to another physician, and the patient shares that data element, that might be a use case for the 99091 by a different subspecialty. But yes, RPM is very complex. So,
and I would agree with that. There is that use case. And again, that would take the coordination between the providers, which is a whole nother discussion. But on the next slide, I'm going to get to some of those, you know, expand on that a little bit with some specific code documentation considerations. And so that was a great meet up, Amanda. So the new remote patient monitoring codes, there's a setup and education. Okay, so that documentation, you want to make sure that there's a summary of who did the education, and that monitoring will be a minimum of 16 days. Collection of the data and programming, that's really probably going to be a flow sheet within your EHR of the digitally collected data over a 30-day time period. Now, I pointed that out because the professional component of this, the 99457, and then the add-on time of 58, the care team communication with the patient provider is over a calendar month. So a couple of different times there. Some, you know, so just just make sure the counting is right. I've known situations where Medicare has come back and, said, you guys don't know how to count because they missed it by 1 day or, something. So there's an important, it shouldn't matter, but there may be cases when that would kind of put you off on timing. But that care team communication, again, probably is a flow sheet of the ongoing documentation from each care member, because it may be multiple. It may be an MA at one point, a nurse at one point, the provider at one point, all talking with the patient throughout the month. And then that's where we get into that. So those are the newer codes. A couple of the things that Amanda, that I'll expand on, that Amanda mentioned, is this 99091. That was kind of the original RPM code, that what you could use. Most people didn't pay it. We never bothered with it, right? But it could potentially be used for a use case that was something that wasn't digitally submitted, because that's not required for this code. It is just the provider time. So it's not any of the other time that occurs. It's the care team communication with patient provider. There's really, it's all the technical professional all bundled into one, and it's more time than is required for the 99457. I believe it's 40 minutes, or maybe it went down to 30 minutes. Amanda, I'm not sure if you know off the top of your head.
It's 30 minutes.
30 minutes is okay, baseline. And there's a discrepancy between the CMS and AMA on this. CMS says we do see scenarios where you can bill this, but if you look in the CPT book, they're going to tell you that it cannot be reported on the same day. So I would just put the caution out there that it probably would not be, we would not expect to see this on a regular basis, but CMS has said that they intend to, they do see cases where it could. And I think Amanda very well outlined what that could be. And again, coming back to that point of another provider, so there are actually separate codes for blood pressure monitoring and CGM that are more specific that could be used, so that endocrinologists that's doing CGM would report, the appropriate CGM codes, whereas someone else that's maybe doing pulse ox or weight or whatever for another condition may use the newer codes, and it's digitally transmitted. So can be some differences there. Coordination is the key. Otherwise, it is kind of first come, first serve, whoever pays, and then it's often, if you're in the same organization, there can be some appeals or whatever, need be. But this is going to take this is going to be changing and evolving. That's what I'll say. It's going to be changing and evolving. There's going to be updates, just because it is so gray now and these questions are out there, and we don't have the answers yet. So it'll be interesting to see how it all plays out.
Yeah, and I would add, in addition to it being gray, since it was approved for reimbursement, every year since, the rules have changed.
Yeah.
Yeah. So with that, which was, a very quick high level overview, again, all of these things could probably go into, multiple discussions in more in depth, but that's high level, and hopefully we're going to drive home some of the key takeaways in a little bit. But first, I'm going to hand it back to Amanda to talk about what we all need to remember, and that is around the medical necessity, which drives any visit, whether it be telehealth or in person.
Yep, can you go to the next slide? Thank you. So I'm going to talk specifically around some of our New York laws. So in 2016, we had Article 29G that was passed in New York that described telehealth delivery services and explained that commercial payers should essentially not pay for the telehealth services just because of the modality utilized. And the way in which they phrase this is a service delivered via telehealth to a reasonable utilization management and quality assurance requirements that are consistent with those established for the same service when not delivered via telehealth. So we do know that, you know, the public health emergency kind of was a free for all with all the regulations and different changes and allowances, and the expansion of, I believe, a list of codes that was initially 80 became 180. I always go back to this when I'm speaking with my providers. So our initial fight in telehealth was to be treated as if it was an equal to the office. And that's what's based in our law. So some key items in here is the modality that you're utilizing should be an equal alternative to the in-person visit, right? So the codes that you're using, you know, if you're using your regular office codes with a modifier, it's just saying how you perform the service differently. The other code sets that encompass the modality into the code aren't telephone call codes, right? They're still evaluation and management services that include the addition of the modality. So you still have to meet those elements that are encompassed in all of our evaluation and management services. So utilization of the modality alone does not make the service reimbursable, right? It's just a condition of the service. Another thing to keep in mind is accessibility is not equal to reasonable and necessary. So our overarching criteria in any of the services that we submit for is that the service has to be reasonable and necessary. So just because there's a telephonic code that's available, you know, and the modalities are accessible, just, you know, keep in mind when you're performing certain services that you didn't bill for in the past, just because there's a code that encompasses that modality doesn't mean that service is now currently reimbursable. So some examples include you send a patient for blood work. In the past, you call them, you say, everything looks good, I'll see you in 2 weeks. Just because you made that phone call now doesn't mean that you could go ahead and submit the 99441. There's no changes to the plan. You're just confirming the results. And there's really no reasonable and necessary assessment and plan set up from that service. So, yep, just things to keep in mind when you're deciding if you should bill for the service you provided based on the modality that you utilize.
I think that's a great point, Amanda. I just want to jump in and say that, you know, and I think some of the guardrails they put up with the audio only phone calls or these e-check-ins now or virtual check-ins is that 7-day window, right? That it can't be related to, but I don't think that will capture it all. But that you made a good point in thinking about, would I have brought this person into the office for this, or not necessarily brought the person into the office, but was something changed in the plan of care? Did I adjust the medication based on what the patient's telling me during this visit? Those things should be thought about to kind of give you an idea of, is this a medically necessary service?
Yeah. Especially understanding, you know, Chrissy went over the different criteria, and did you meet all conditions of the code outside of the modality, right? Did you have a reason for the visit, a review of pertinent history, and a determination around an assessment and plan? Or was it simply a form of communication based on something related to a prior visit or a notification before an upcoming visit?
Any questions? Medical necessity is always that thing we don't want to really talk about because it is so nebulous.
I don't think we have any questions in the chat, but that's a good distinction that you just made. And Amanda, I like the way you explained that, the difference between medically necessary and convenience.
Yeah.
Okay. So now we come to the end, and I know we're coming up on time, so we're going to get some key takeaways here. I'm just going to start with just go through the specific services we talked about, and then Amanda will wrap it up here with she'll land the plane with some real broad overviews. So parity telehealth services, again, documentation guidelines remain the same. They're the same. They actually now just have to take other things into consideration, recommend using scripts, templates, prompts to capture those components. And it's with the specific telehealth modalities. When you get into audio only, during the PhD, it was a little bit of a mess. There was a lot of ways to report this. So recommend having an organizational policy around this as you start to move forward so that there's understanding, as we just talked about, around medical necessity, what counts, what doesn't. Maybe you have someone review that because sometimes the provider isn't, moving very quickly and doesn't know, isn't making that determination necessarily. Check with your payers because they're going to change their policies, I'm sure, during this time, and potentially add in those evaluation, those telephone E&M codes as payment as permanent going forward. E-visits, use your portal message as the actual documentation if possible. It's a time-based code. Oh, in the audio only time-based code also. Don't forget, make sure you document time. The e-visit is over a 7-day time period. And again, leverage your portal EHR vendor for workflows and templates. And then remote patient monitoring, there's some general considerations around remote patient monitoring, and then some specific code requirements. And really keep in mind that this is a very new space and it's going to look different over the next few years as it develops and evolves.
I would say as well, this is Michelle, and I know we're short on time, so I'll say it quick, but we also are getting, in South Carolina, where I'm based, OIG did a review of some claims here. And because the policy and procedure said that they had to document start and stop time, and that wasn't necessarily necessary for that service, that OIG took back quite a few millions of dollars because the policy was not in line with practice. So same thing there. I would say make sure your policies are in line with the practice.
That's a great point. And include all these things in your compliance plan is what I would say to do some general monitoring. So now I'm going to let Amanda land the plane and finish this off.
Okay, so I'm just going to go over, we get a slide at the beginning, a brief history on the past and present of telehealth, and essentially beyond what we're talking about just for audits is also, whatever we're doing today is really going to help build the future in telehealth. So in the past, we had significant originating site restrictions. In addition to that, there was a large amount of restrictions about if home was even an allowable site, and at home, what kind of services were able to be performed. And in the prior world, pre the pandemic, there was a lot of direct-to-consumer markets out there that did self-pay visits via telehealth, and they typically targeted the low acuity patients and conditions. Then during the public health emergency, we had essentially an elimination of the restrictions around the originating site. We had a complete expansion on services allowed to patient home. Essentially anything that was on the list of codes and the expanded list of codes that was allowed to be performed in the office was now allowed to be performed in the home. Regulatory requirements broadened. So by that, I mean, certain rules that we had, including incident 2 and direct supervision, in order to make the possible to perform it to home, regulatory rules had to change to make those services feasible. So the reason why this is relevant is the PHE accelerated the need, right? So we needed to figure out how we were going to translate our typical office visits into an audiovisual platform. The current proposals that we're seeing for future regulations still challenge the appropriateness of services to home. So we were able to show that we were able to do it, and they're still questioning how it can be done. One thing to keep in mind is these regulations are still being formulated. You want to go on the next slide? All right. So as mentioned, we don't expect the future to be a mirror of today. It's going to land somewhere in between the past regulations and the present regulations. So we do expect some originating site restrictions will be reevaluated. We believe that the federal allowable list of services will be reduced and revert to the prior approval process. So for those of you who are not aware of the prior CMS approval process, there are 3 categories by which you can ask to have a code considered to be part of the entire list of telehealth allowable services. So it's going to revert back to that process. So even codes that are set to term at the end of the public health emergency, in order to get them re-added, you would have to see if they meet on a category 1, category 2, or category 3 basis. Adjustments to the regular requirements will be made. So again, we're not 100% sure around the direct supervision guidelines and the incident 2 guidelines related to these services. Are they going to continue to allow some of those items to be met via audiovisual technology? Or are they now going to require the physicians to be active at the same location? The data and clinical use cases established and derived from the PHE. So whatever we're doing today is going to be significantly important to the future allowances. So if we could prove that we were able to do it now, that subset of cases is essentially what's going to be used to ensure those codes either stay or get reevaluated on that category 1 and category 2 and category 3 basis to be re-added. So if your documentation justifies the appropriateness of the services performed today, it will defend the continued use of the modality in the future.
And that's a wrap.
That's a wrap. Thank you so much, Christy and Amanda. There's so much here. We could do another webinar for sure. I know that we've had quite a few attendees on this webinar, and we didn't have any questions in the chat. And I know some may need to leave, but contact information is here if you want to connect with anyone or ask them further questions. I think there is so much meat here. We probably will do another webinar in the future, probably, sometime in the fall for Christy and Amanda to work on. I think they were a great team on this presentation. Thanks everybody for being on the line. I really appreciate it. I've got a chat up there, but I can't quite see it. But one of the things that we did ask, someone did ask a question around, was if we do see insurance denying a charge, will you, I should say before I ask that question, please make sure for everyone that they follow us on LinkedIn as well as Facebook and Twitter. We share a lot of articles, a lot of free information. We tell you all about the next webinars that are going on, so make sure that you like and follow that. But if we do have a charge that was denied, let's say for a particular telehealth service, is it allowable to send that charge to the patient? Is this come into the line of surprise billing for patients?
That's a great question, I think, and that's where the consent piece comes in. And it's important that, okay, the patient realizes this is a billable service, and if not covered by insurance, it's the same thing that would happen as if it was not covered in the in-person setting. So that's where that consent is important. And unfortunately, not most people don't read consents. I've been thinking about that recently, that almost everything I check off to say, yeah, I'm signing it, I don't read closely. Right. So there may have to be some discussion with patients and some guidelines within your organization to demonstrate that you are not violating the surprise billing regulations that are out or coming up.
Yeah, I would agree. And then, thinking of the future of Medicare, again, we're not 100% sure what they're going to do in the post-public health emergency. Is making sure you have those ABNs, and there are ways of reporting with certain modifiers to Medicare with knowledge that you have an ABN already on file and that you understand it's non-covered. And you could report it appropriately to them, which would result in the patient getting the bill and avoid the surprise billing problems.
Yep. Good point. Thank you, Amanda. Thank you, Christy. I know we're way over time, but we'll do this again in the fall. Thanks everybody for attending. Again, this is recorded. So if you missed it or you have a colleague that wants to listen to it, it will be on our website. Have a good day.
Thank you.